So my mainstay previously has been a carbide burr, which is basically a metal tip, and we have to have separate suction, separate cautery and all. And you know, the problem with that machine is just it goes very quickly, and bleeding's often an issue. If I have a lot of bleeding, I have to end up adding bone cement to pack off the area that's bleeding, and that takes up the very space I'm opening. So I guess a better thing is explaining what procedure I'm interested in this for, and that would be orbital decompressions. So people that have hyperthyroid related disease, autoimmune problem in the orbit, their eyes are bulging forward. Think of it as an ice cream cone where the space gets occupied more and more with swollen tissues. So the answer is in opening a wider space within the bone, and our only options are the floor of the orbit, the sinus down below, the inside wall with the sinus there, ethmoid sinus, and then the scary, one of the most effective ones is the deep lateral wall back in here, which is between the brain, inside this cap here, and the orbit. And I actually intentionally want to take down the marrow space until I see the dura, which is the lining of the brain, but obviously not penetrated. So I'm pretty excited about the potential of using this thing for this device with its ultrasonic tip to be able to do that safely. So you can see the irrigation. If you can see that was actually spray coming out. My hand's getting wet there. And it's got suction at the same time. And I've been told, I'm going to try this out, but I've been told I could actually hold it against my hand, not cut my hand, because the ultrasound is bouncing away hydrated tissue, whereas the bone can't bounce away, so it's trapped to be injured. With colors, we're showing areas of bone that I take out. We need to zoom that a little bit. So again, this is the medial wall with the ethmoid sinus behind it, not the nose, but the ethmoid sinus. The floor of the orbit with the maxillary sinus, which is down below here, and then this is the lateral wall, including the deep lateral wall, which is defined by these two fissures where some of the nerves come out, and in between is where I take this bone out, and what's behind that bone is the temporal lobe of the brain. So obviously we need to be careful there, and I'm really interested in that part of it. So I usually take out bone medial and lateral wall. Back that out again. So a balanced approach to avoid double visions. I take the medial wall out and the lateral wall out. And I only take the floor out if it's really necessary, because patients got severe protrusion of their eyes. The problem with the floor is that the eye can settle some, so be very careful with that. That's why I leave this little strut of bone here and a strut of bone here to keep support intact. So. And this can be also dramatic for saving the vision of people. I've had patients that would wake up in the morning literally with barely able to see finger counting. And then within a week of surgery, back to like 20/20, 20/40 vision, just reducing the pressure on the optic nerve to being squeezed in the back. So as much as the cosmetic thing, it's actually really a vision sparing surgery. All right, we'll go ahead and treat this then. We need to wet it at all now? Or
nope.
Not? Okay, great. So I'm just going to go back to the lateral wall I was doing earlier. You can come below if you can just see it okay.
Oh no, that's good.
Spray a little water, make them. You have to dry that periodically here.
Very good.
Heather, yeah, can you be an assist? Just get a.
Actually, I can. I can get a
So there is actually suction associated with this, but it's not enough to keep up. Looks like completely.
I just turned up the suction, so it could prove a little bit on you.
Tip is warm too, I will say.
You turn down the power.
You can pretty much see that clearing the bone out there. So you can see that area has been thinned, and I would take this down all the way until I literally saw the dura, which is again a lining of the bone. So the dura it's pretty tough tissue, and I guess it's has a lower water content, so this ultrasonic tip can push against it, but it just doesn't cut through it very easily unless we're forceful. That's true of anything. We can sculpt that away. So the medial wall, normally the way I take that down is pretty incredible. I can do about three suture closures, about maybe a 10 millimeter incision through the lining of the eye there, and afterwards the stitch is dissolved, so it's really a pretty much invisible incision. By the way, this one here is done through an eyelid crease incision. So typical cosmetic surgery, just a little scar right in here. So there's access, even though it's like a pretty aggressive surgery, really everything's done, pretty minimal morbidity. But anyway, what I was going to say is, typically I take a device and just knock the bone inward. And it bleeds, but we use thrombin to quiet it down. But obviously it causes a lot of swelling, so if I can do it in a more bloodless manner, it makes more sense. So in reality, this is some of the thinnest bone in the entire body, called a lamina papricia, and that would probably go through just, imagine one little pass. Beyond that would be mucosal lining for the sinus, and I would just push that away from me basically. Wouldn't have to necessarily get rid of it. The floor is the last place, and this also I typically break out. So, interesting little sidebar is that if somebody gets punched in the face or takes a blow to the eye there, instead of the eye rupturing, very often that thin bone here will blow out, we say, and the contents of the orbit will drop down, and then the person's eye can't look up because she gets trapped. So, in a way, we're creating an intentional blowout fracture, but creating a wide enough opening where the muscle doesn't get trapped. So, we'll try that one too. So another advantage here, do you see that little hole right there? So there's a little artery comes out there, but there's also the infraorbital nerve comes either through the floor, sometimes penetrates through a foramen over here too. And that nerve is injured, you get a lot of numbness down here, so having a precise device should really help protect that nerve. Alright, well, again, I'm not going to take this all the way down and through, but you get the idea that this should be a safe way of opening up bony spaces for decompression. And then the floor I access via a little tiny incision in the outside corner and an incision on the inside of the eyelid. So when all said and done, the person would have a scar on the upper eyelid, completely hidden with their eyes open. Invisible scar here with no stitches that show, and then about 3 millimeter scar on the outside corner. That would be it. So at some point I can tie in and show some before and after pictures of people look like when they had this procedure done. So thank you, I'm excited about this. This is amazing, actually.
I know, I love it. Are you doing okay like that? Yeah.